good afternoon, and thanks for joining today's webinar. A few housekeeping notes before we begin. Next slide, please. In this platform, all attendees are muted. While you won't be able to ask questions through audio, please note the Q&A box on your screen. If you have a question that is not addressed in the presentation, please submit through the Q&A feature, and our speaker will try to address as many as possible at the end. Also, today's webinar is being recorded. As a registrant of today's session, you will receive an email with the link to view the recording on our website once it's available. It's now my pleasure to introduce today's moderator. Next slide. Dr. Claire Sullivan is a preventive cardiologist and lipid specialist at University Hospital's Harrington Heart and Vascular Institute. In addition to her patient practice, Dr. Sullivan serves as Associate Cardiology Fellowship Director at University Hospital's Cleveland Medical Center and the Louis Stokes Cleveland VA Medical Center. She's authored more than 30 publications and presented at multiple local, regional, and national conferences on topics related to preventive cardiology care. I'll now turn it over to Dr. Sullivan to introduce today's special guest speaker.
Thank you very much. And it is truly my pleasure and honor to introduce a colleague and definitely a wonderful friend, Dr. Sudhir Al-Kindi. So Dr. Al-Kindi and I have known each other for several years now, going back to his intern year residency at University Hospital's Cleveland Medical Center. Knowing from day one when he came and discussed with us about research ideas, truly how motivated he is, not just as a clinician, but a researcher. And that has only proven true throughout his training and residency fellowship, his attending them, and thus beyond. Dr. Al-Kindi is currently on staff at Houston Methodist Hospital. He is affiliated with a program called Cinema at University Hospitals as one of the founding members and very prolific researcher with topics related to cinema. His interests lie in preventive cardiology as well as cardiac imaging. And very excited today to hear his discussion about building blocks of health, how neighborhoods influence cardiometabolic well-being. And thank you, Dr. Al-Kindi, for being here today. It's wonderful to see you.
Thank you, Dr. Sullivan and Tiffany, for the kind introduction, and I'm honored to be here. And I thought today that we're going to talk a little bit more about something that is not specific to medical care. It's not something that we talk about all the time, something outside the box, so to speak. So we'll talk a little bit about the impact of neighborhoods on cardiometabolic well-being, and I have no disclosures. So the objectives of this talk is to explain the impact of neighborhood and communities on cardiometabolic disease. That's inclusive of kidney disease risk, heart disease risk, diabetes risk, obesity, and other things. We'll also discuss the recent evidence on the effects of some of these evolving measurements from the neighborhood, measurements of socioeconomic status, the built environment, natural environment, and how do access to care impact cardiometabolic health. And then we'll also touch upon this a little bit about some of the strategies to address some of the neighborhood level factors, what can patients do, what can clinicians do, and with regards to cardiometabolic disease. So the background is that we know that cardiometabolic disease, cardiovascular disease remain the global mortality and morbidity. In fact, more than 30% of cardiovascular and cardiometabolic morbidity and mortality are not well understood. And we think that they're really attributed to kind of poorly understood factors, inclusive of the environment, occupational risk factors, some socioeconomic deprivation, and other things. Environmental, as an example, when we estimate environmental impact on cardiovascular disease, it's estimated to impact approximately cause 9 million deaths annually in the world, most of which are actually due to cardiovascular and cardiometabolic causes of death. And there's really a need for us to understand the kind of the small environment around you in the neighborhood, at your home, but also outside your home, in the neighborhood, in the communities you deal with, and really how can we integrate all of that into our understanding of cardiometabolic disease. So if you just take a quick look at the map, and this is not a surprise, but if you look at the map of the United States, this is just an example of cardiovascular mortality per 100,000 people. And these are adjusted for age, so age is not an issue. And you can see here that there are significant differences in terms of cardiovascular mortality when it comes down to different areas in the United States. And these are after accounting for the number of people who live this. So this is not because some people live in, more people live in different counties, but also adjusted for age. And you can see the differences here. This is in red here in this area. There's about 500 people dying every year per 100,000, while in the blue areas, there is 64. So we have a tenfold difference in kind of cardiovascular mortality throughout the United States. And in some examples, we see neighboring counties. So for example, this here, if you can see it, there are neighboring counties where there's tenfold difference in cardiovascular mortality. This is not only in cardiovascular mortality, but when you look into geographic variation in risk factors, what we call traditional risk factors for cardiovascular disease, you see the same story. You see that some areas that have very, very high levels of blood pressure and severe blood pressure that's not controlled, and the same thing that applies to diabetes, while there are areas that have no significantly less prevalence of some of these issues. So the question is, what is really driving some of these differences? And for those of you who watch TV, there's a recent show on Netflix that looks at the blue zones. And these blue zones are kind of the extreme health, people who live up to 100 and more than 100 consistently. And it's always been the question is, what is it that about these people that makes them live to 100, healthy, aging? What makes them live in an area? And a lot of the focus has been about, okay, you have to exercise. Oh, you have to eat healthy. These people eat healthy. These people exercise. But that's not the entire story. The real story is revolving around outside just your own behavior. What drives your own behavior? What is the neighborhood around you? And what is the city that you live in? Makes sense. Because if you take these people who live more than 100 from some of these areas and you put them in different areas, they don't live up to 100. They don't live even up to 90 sometimes. So there's something about the environment that makes us either live very happy and healthy or, die suddenly and early. So I want to convince you today that where you live matters. And oftentimes there are some cross-sectional studies. These are kind of what we call the first level of evidence, where to link, people live in this area, that they live long, live in this area, they live short, then that means that there is an association between where you live but it's not causal relationship. So how do we know that where you live matters and that has an impact on your disease in a causal fashion? This is a very smart study that was designed by the Department of Housing and Urban Development back in the early 2000s, actually in the 90s, where they took people who live in high poverty areas. And these are women and children who have some obesity or heart or diabetes. And then what they did is they took them and they randomized them to three approaches. One approach is they said, we're not going to do anything for you. And we're just going to watch you and do nothing, right? This is kind of the usual care. And another arm, what they did is they gave people a voucher, a housing voucher, and they said, you can use it the way you want. If you want to use it, if you don't want to use it, if you want to use it just to pay for your rent where you live, that's fine. And then in the third arm, which is the interesting arm, they gave the vouchers only to people who are willing to move out of their house to a community that has a better living situation. And so that's what they did. And this is a big study of approximately 4,500 women and children. And most of them were living in high poverty area or kind of socially deprived area. And then they followed these patients up to 10 years. So what they showed, which was really interesting, is that at 10 years of follow-up, you have significant reduction in people who are obese. If you were in the low poverty voucher, where basically you're given voucher only if you wanted to move. A lot of people moved out of their homes to an area that has better living conditions. And basically, you had lower prevalence or incidence of obesity. You had lower incidence of severe obesity as measured of body mass index of more than 40. And then you had lower incidence of diabetes. And this is a measure of diabetes that we use as hemoglobin A1C. So because this was a randomized study, which is the highest level of evidence we know, then this tells us that where you live matters in a causal fashion, at least with respect to obesity and diabetes, and at least with respect to women and children, right? And this was a study over 10 years. So we know that it has at least an intermediate to long term impact. There's this another clever study which was done using the VA medical record system, where they took patients who have, they followed patients who moved from one location to another location, from one zip code to another zip code. And what they saw is basically if you adapt to the area that you move to. So if the area that you move to have higher blood pressure, will have just so happen to have high prevalence of high blood pressure, your blood pressure is going to increase, right? If you move to an area that has low blood pressure, your blood pressure tends to decrease. And this happens almost immediately within a year or so of moving. This is the time, zero is the time of move. The same thing happens with diabetes. If you move to an area that has high prevalence of uncontrolled diabetes, then you see an increase in the prevalence of your uncontrolled diabetes will increase. And the same thing happens if you move to an area that has a lower incidence of diabetes. And the same thing applies for obesity, depression, and other conditions. So again, that gives you another layer of support to the data to suggest that where we live matters. This is a very this is something that that's spoken about in the medical literature a lot, but also in the socioeconomic and the economic literature a lot. This is the Delmar Boulevard in St. Louis, Missouri, and what you can see is that there is a huge divide in this, where you have significant kind of segregation, both racial and non-racial segregation, that this street happens to separate the two. And I don't need to tell you, you can just look on this picture of this street, and you can tell me which side is the kind of the socially deprived, socioeconomically disadvantaged neighborhood versus which one is the better one. But what you do see is that this divide, the kind of the segregation between the neighborhoods leads also is almost superimposable on heart disease mortality. This is the same map of St. Louis. You can see the mortality is approximately 5 to 6 fold difference for cardiovascular disease and cancer mortalities. So we have been in medicine, we've been really super focused on one thing, or a few things, right? In cardiology, we focus on the heart, and we, measure all sorts of things. We do an echocardiogram, we do, CT scans, we do heart catheterizations and stuff like that. The nephrologist, the kidney doctor is going to look at your urine and do things and so on and so forth. And we've been very focused on what happens in the human body, because that's, as clinicians, that's what we're trained for. But in reality, as a human being, we're exposed to so many different things. And, you can think of education, air quality, the temperature where you live, the food environment, noise, light, greenery, climate, all that stuff. And we don't fully understand how this impacts our health, although we're exposed to it at every second of our lives. But beyond that, we also have our social networks. How are we connected to people? Our genes, our microbiome, which is the measure of how much, bacterial activity and other things happening in your body. We also are surrounded by a lot of health data that we measure using wearable monitors and things like that. So how can we really think about this in a more holistic fashion? So this is the second time I think the AHA, the American Heart Association, came up with models to understand how can we live happy and healthy. And in this last year, they just came up with this Life Essential 8. And these are things that make sense. Kind of don't smoke, eat healthy, measure your blood pressure, control it, control your lipids, and so on and so forth. These are 8 of them here. But then now they're starting to think a little bit more outside the box, so to speak, and understand that social determinants of health and everything that they incorporate, including the individual, the interpersonal, the structures and community and the systems, actually also impact health in a dramatic way. And I would actually go a step further, and I would say that there is something that's called the exposomes. Basically, it's a play on the word of exposure and whatever you're exposed to. So beyond air quality, beyond green spaces and noise and light, this is the external exposure. There's also the personal exposure model, which basically your diet, your physical activity, your work, your sleep, social network, and smoking. And of course, these all have a significant interplay with the biologic responses. So that leads to aging and stress and changes in your gene expression and other things. And just a few days ago, this came out, and Dr. Neeland, who's the co-director of cinema, is an author on this. This is the American Heart Association statement that looks at cardiovascular, metabolic, and kidney syndrome. This is kind of a newly termed syndrome that we've known about for a long time. And interestingly, they have this figure, which is one of the central figures for this theme, which really takes into account not only what we think about, fat, kidneys, pancreas, and heart, but now we start to think outside. What are some of the proximate impacts of the societal factors, including social needs, community factors, including chemical exposures in neighborhood and things like that, relationship and behavior. So it's more of a kind of a top-down approach to understand what impacts your health at the end of the day. And of course, what I presented is a simplistic way of looking at this. And this is another schema that looks at the complex interaction of everything else that we talk about: genetic predisposition, inclusion of internal environment, external environment. And there's just to bring you the awareness that it's a complex story, and that affects us throughout the life course, right? It affects us from the moment we're born, and sometimes there's some data to suggest that it affects us even when we're in the uterus, and then affects us throughout the life course. So what is the impact of this? And this is, how can we characterize the impact of this? And this is just one aspect of it. But if you look at pollution, environmental pollution, as I mentioned, that leads to approximately 9 million deaths. And this is higher than tuberculosis, AIDS, malaria, alcohol abuse, malnutrition, road accidents, all combined, right? So the degree of this problem and this is only one domain of what I spoke to you about, right? This is only environmental pollution. Environmental pollution is more responsible for more deaths annually in the globe than all of the other things that we've been focusing about heavily in medical school training and even in the news combined, right? So that's a big issue that we have to think about and address. And we've known for a long time now, thousands of studies, that air quality, this is measured by, particulate matter, PM in this case, it's been associated with incidents of heart disease outcomes in a linear fashion. So and this relationship really here continues down to almost zero. So there's no safe limit to how much air pollution you can be exposed to. And think of it as cigarettes, right? And there's no limit to what is a safe number of cigarettes that I can smoke. Same thing applies for air quality. And it turns out that there are some of the patients that we do see as cardiologists are even more susceptible to the impact of air pollution. So this was a study that we looked at patients who are kind of extremely risk, have heart transplants, heart failure and heart transplant. And you can see that the association between air pollution and mortality is higher here compared with the other studies that looked at the association, which was about 10%. Ours was about between 25 and 30%. For the same degree of increase in air pollution. Same thing applies to patients who are susceptible because they have blockages in the arteries. So this is a study that we did using the Veteran Affairs Hospital data. And we showed that if you do get exposed to a higher level of air pollution within the levels that we see in the United States, so this is equivalent to you moving from Cleveland to somewhere in Seattle, for example, right? You do gain approximately 2 years of your life if you're having a stent and you move from one area to another that has lower exposure of air pollution. Beyond, there's a lot of talks about air pollution, but there's other things that we don't necessarily think about. So noise, occupational noise, transport-related noise, how close you are to a traffic highway, for example, and you hear the cars moving throughout that road can also impact your health. And there is a lot of literature now to suggest that we started to understand how this traffic-related noise can actually lead to biologic differences and changes in your arteries and your other organs that can increase your blood pressure, increase the obesity risk and the arrhythmia. And there's a lot of research that's ongoing in this. So this is one of the studies, one of the largest studies that were done. This is 500,000 patients in the UK, in the United Kingdom, where they looked into the association between exposure to road-related noise and incidence of high blood pressure. And you can see that the higher the risk, the higher the exposure you get to noise, the higher the incidence of new diagnosis of high blood pressure. And this is independently of the impact that you see from air pollution. This is a recent publication that where we did is we combined data from interventional studies where a group of researchers have done analysis of giving people some noise, simulated noise, similar to what you get exposed in the roadways or near airports and other things. And we looked into the composite impact of vascular health, blood pressure, how you feel in the morning, and then restfulness. And this is exposure to noise during sleep. And we saw that there is a consistent impact and effect of the studies on flow-mediated dilatation, which is a measure of vascular health. We saw an impact on increase in blood pressure. We saw an impact on worse feeling in the morning and restfulness and worse sleep quality. So this gives you, because of the randomized fashion of the studies, this gives you a high level of evidence suggesting that what we see in the relationship between noise and cardiometabolic health is causal effect. We also have looked into other things related to the neighborhood, including how walkable your neighborhood is. So this is a study, a nationwide study that looked at in the United States in 2020, do people who live in walkable areas as measured by the number of kind of sidewalks and the least, the more walkable, there's a walkability score that we measure. And then we saw that people who live in neighborhoods that have high walkability score, they have lower blood pressure, they have lower cholesterol, they have lower obesity, and lower diabetes, and of course, as a result of all this, lower risk of coronary artery disease. So, and some of this effect is mediated through blood pressure. Some of this effect is mediated through high cholesterol, the relationship between walkability and coronary disease. Some of it is mediated through reduction in obesity, and some of it is mediated through diabetes. And the combined effect is really significant. So there are direct effects on risk factors of cardiometabolic disease, but also impact on coronary artery disease. So, not only what you're exposed to in terms of active things going on like air pollution or noise, but also what you're exposed to in terms of food environment. This is a study where we looked into the quality of food environment. So within each county, for example, how many food, grocery stores and things like that are available to people, fresh food and so on and so forth. There's a food environment index, FEI, which is from the US Department of Agriculture. And what we did is we looked into the association between food environment quality and cardiovascular disease mortality. And we saw that basically the lower the food environment index, which is basically poorer food environment, is associated with significantly increased risk of cardiovascular mortality. And it turns out that there is an interaction, meaning that this impact is accentuated in counties in the United States that have high income inequality. So if you layer income inequality on top of poor food environment, you will have a significant impact on cardiovascular mortality and cardiovascular disease. The social environment is critically important. This is not your natural and built environment, but this is your social environment. And understanding the social environment is critical because it's part of your social determinants of health. And what social environment is basically how does the neighborhood that you live in um, uh, 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 basically fare in socioeconomic status, in household composition, disability percentage, minority status, language, and housing and transportation. So this is an index that we used as a surrogate for the social environment. This is called the Social Vulnerability Index. This is from the CDC, and it incorporates all these factors that you see here on the left upper corner. And you can see, for example, if you were to see how this social environment looks like, it's the red is bad and green is good, red is good, blue is good, and you can see that there's significant heterogeneity in the United States. So we looked into the prevalence of high blood pressure, and the higher the social vulnerability or the poorer the social environment of the neighborhood, the higher the blood pressure, the higher the diabetes, higher smoking, not so much in cholesterol, but significantly higher increase of prevalence of low physical activity and higher obesity. And these are independent of the age, the race, the composition, the other factors that we take into account sometimes. And so we started to layer some of these impacts. All of the studies that I've showed you are isolated studies looking at each factor separately to understand the impact on cardiovascular disease. And now we started to layer those. So now in this study, we're layering air pollution or air quality on top of social vulnerability. And we see that the higher the air pollution here on the x-axis, the higher the cardiovascular mortality. But this relationship is steeper here in people who live in neighborhoods that have high social deprivation or high social vulnerability. So this suggests that, if you were to reduce air pollution levels in this group of patients, you would get better benefit for cardiovascular mortality reduction. All the studies that I showed you thus far are talking about current exposure and current outcome, meaning I'm exposed to noise right now, and I want to look at cardiovascular disease right now. I'm exposed to air pollution right now, and I will look at cardiovascular mortality right now. So we also sought to study what is the impact of intergenerational disinvestments, intergenerational poor exposures on the impact on cardiometabolic health. So this was one of the first studies that we did looking at redlining, which is a practice that happened in the 1930s where people were getting segregated based on their race and other factors and were denied mortgages in different areas. And of course, this got outlawed with the Fair Housing Act. But you can see, for example, this is Los Angeles, where you can see the maps were divided by color, and red was basically the hazardous part of the population. So we wanted to look into how does that impact this thing that happened a century ago, decades ago. We wanted to investigate how does it impact the health of the current day population in the United States. And we looked into 11,000 neighborhoods or census tracts, and we saw that the prevalence of cardiometabolic risk factors, including diabetes, smoking, obesity, high blood pressure, and cholesterol, increased linearly with the degree of redlining that happens. And as a result of this, we had higher risk of cardiovascular disease, including coronary artery disease, stroke, and chronic kidney disease. It was not surprising to find this, but what was surprising to us was the degree of the relationship. Now we're looking at 30% increase, relative increase between the green zoned and the red zoned areas. And this is just an example of how Northeast Ohio looks like. So this is Cleveland, this is Lake Erie, and you can see that Cleveland, actually, you see all the four colors. Similar to what you see in the seasons, you see literally all four colors here in Cleveland of redlined areas that are in the inner city for the most part. And then you can see the intertwined neighborhoods between B, C, and D, where A, B, and C, where the red line are in the middle, the green are in the periphery for the most part. But if you were to look at the map in just looking at the prevalence of coronary disease, the prevalence of stroke, and prevalence of chronic kidney disease, these maps are almost superimposable on this map. So, you can see that the coexisting of this decades of disinvestments into neighborhoods that led to poor environments, poor living situation, poor neighborhoods, more lead exposure, and other things that led to coronary disease and cardiometabolic disease. So we were intrigued by this finding, and we wanted to understand to what degree is that related to just environmental exposures. So we looked again nationally at what happens in red line neighborhoods in terms of environmental exposure, and we saw that they have red line neighborhoods have a closer traffic proximity, which is bad for health. It has more wastewater discharge indicator, higher air toxicity, different, through across the board, you can see that there is higher impact of the environment, adverse environment that has been linked with health in red line neighborhood. And that's really where we started to think a little bit more clearly about how we can understand the changes in the environment over time. So there's more ongoing work in this space. So we spoke a lot about your exposure, but there's other things that are really turning out to be really interesting. So this is a study that was done by one of our UH residents with me, where we looked into the economic connectedness, and this is basically how how rich your friends are if you were poor, right? So depending on how the income inequality between your neighborhood, but also as an index person who does not, does not have the economic impact or the economic kind of the abilities. How does the network of friends that you have can impact your trajectory? And this has been done by the Harvard group, where they looked into this metric where they actually acquired it from Facebook, and they looked at each person, how many friends do they have that have a higher socioeconomic status, and they mapped this throughout the United States. We were interested in looking at how this relates to health, and it turns out that if you divide the population into quartiles of income, so this is the lowest income of disease, of lowest income quartile, and this is the highest income quartile. And you can look at the age-adjusted cardiovascular mortality. You can see that across the board, the higher the income, the lower the mortality, which has been shown before. But what's interesting is that if you do have high economic connectedness, meaning you have richer friends than you are in the neighborhood, then what happens is that your mortality actually decreases. So if you were living in an income quartile one, the lowest quartile, and you have rich friends, your rich friends will make you make the mortality in that neighborhood much lower, as comparable to what happens in quartile two. This is just an intriguing finding, but more work is needed because this is still very preliminary at this stage. So I would fail to kind of cover a lot of this without talking about the climate change. I think climate change is going to impact how we live in our neighborhoods. It's going to impact how our neighborhoods are built. And we kind of looked back and wanted to see what is the global impact of temperature changes throughout the past 3 decades on cardiovascular and cardiometabolic health. And we estimated there is 1.2 million deaths that happen globally because of either increased temperature or low temperature, either high temperature or low temperature. And it turns out when you talk about cardiovascular disease, there is an optimal temperature, and there's things that are both high temperature and low temperature has impact on cardiovascular health. And then basically what we're going to see is that what we saw is that the number of deaths has been increasing over the past 3 decades. So this is something to keep in mind, because climate change is going to impact the temperatures globally, and is going to have an impact on our cardiometabolic health. And this is basically both high temperature and low temperature, ice and fire. So, we kind of spoke about a little bit about in the beginning about how to integrate some of these factors and to understand cardiometabolic health, but we didn't speak too much about how can we integrate them into our understanding. So this is work that we've done where we looked into, showed you this map before. This is not different. This is the cardiovascular mortality in the United States. And we started to wanted to understand what are some of the factors in the United States that impact cardiovascular mortality. And we wanted to them because we wanted to understand what policies are needed to actually impact what. And it turns out that median household income and poverty are amongst the biggest influencer. This is using some machine learning and AI techniques, but to disentangle the effect. But what we saw is that household income and poverty, which are closely related to each other, of course, are significant predictors of cardiovascular mortality. And then these are all ranked by importance. But what's interesting to me was that you see that food insecurity showed up as one of the top ones. Broadband access, this is internet access, showed up as one of the biggest influencers. And of course, education is not surprising, physical activity is not surprising, but then we started to see sleep, we started to see other things like air pollution, air quality. So this shows you the importance of integrating some of these factors as part of the exposome or the exposures into understanding of neighborhood health and the impact on cardiometabolic. And it turns out that this is not something that's a global effect, not something that impacts. There's no good one risk factor that impacts the entire continent. What we're seeing is that there are regional differences in what impacts heart health. So this is again another exercise where we looked into cardiovascular mortality and we wanted to look at regional impacts of some of these risk factors. What is the regional impact of food insecurity? And it turns out that food insecurity is not a major impactor of health or predictor of health in the West US, but there are different pockets here where, including Houston area, where you have food insecurity being the major determinant of cardiovascular mortality. While in other areas, education is an important one. In other areas, there's primary healthcare access. And this sort of research is helping us understand what policies are needed in a geographic fashion to understand metabolic health. And then what we did is we looked into kind of how can we integrate a lot of these factors to understand neighborhood health. So in this thing, we came up with a new risk score that really scores some of these neighborhoods. And we did this exercise in Northeast Ohio, as you can see. And we started to kind of look into what is the impact, what are some of these environmental and social factors that are associated with cardiovascular risk. So we integrated them. We came up with a risk score where we kind of ranked the neighborhoods in Northeast Ohio. And what we saw is that the higher the environmental risk, the socio-environmic risk, the higher the event rate downstream, even after you adjust or take into account these patients who had mild plaque in their arteries versus high risk plaque and so on and so forth. And in another exercise, we try to integrate this in another way where we integrated more than 155 factors at the neighborhood level. And this includes everything from your noise exposure, light exposure, green space, access to parks, and all the way to kind of food access and walkability and things like that. And we used some advanced data science approaches, kind of machine learning AI, to classify the neighborhoods in Northeast Ohio into three. So the software where it was able to identify using some of these factors into three neighborhood factors. And these are some of them are here, but they're not, some of them are, you can imagine that they could be inner city or more urban versus suburban, but it's not really that. There's, all over the place. It's not geographically distinct areas, but rather they're distinct by their neighborhood fingerprint. And these had significant impact on long-term risk from a cardiovascular standpoint, even after you adjust for age, sex, and the traditional risk factors for cardiovascular disease. So I'm going to skip through this quickly, but it turns out that there are some other ways to actually also characterize risk. And this is work that we've been doing, looking at some of the models that we've developed some models to characterize risk using some of these remote sensing techniques. These are Google satellite images, Google Street View, and you can actually characterize in these images using AI and machine learning what is in these images that can impact cardiovascular health, and how can we address these to impact neighborhood health and neighborhood design. And skip through this. And it turns out that actually incorporating these information that is embedded in your zip code when you come and see us in clinic has a significant impact on your prediction of risk. So the bread and butter of preventive cardiology is when you come to us, I want to know what your risk is down the road, right? And a lot of the calculators that we use for that risk do not incorporate your zip code, although I hopefully convinced you that your zip code is probably as important, if not more important, than the measurements that we get out of your body. So this is an important message here is that it turns out that the zip code, at least one component of the zip code, which is the social environment, has a significant impact on how we can predict your risk. And the current markers and current risk calculators that we use do not incorporate that. So this is an advancement in the field where we're actually starting to integrate zip code information into this. And this is my vision for the future, is really how can we integrate all this information around us, both environmental exposures, social exposures, with clinical data, with kind of wearables, if you have wearables, if you have images, if you have genomics and epigenomics, integrate them using AI so that we can come up with new systems. These are early warning systems for hospitals and healthcare and cities to understand that, okay, in this neighborhood, I'm going to have during the month of September, I'm going to have high risk of heart attacks. So maybe I can deploy more cardiologists. Maybe I can do screening. Maybe I can see the patients that come from that neighborhood a little bit more frequently instead of annual visits. I can see them every 6 months, or I can pay more attention to them. Also, early personalized interventions. So, for example, if you were expected to have this risk increase during this period of time, then you can maybe take an extra caution in terms of being vigilant about your symptoms and things like that. And of course, real-time resource allocation in terms of screening processes and things like that that we can actually allocate geographically. But there's beyond this, there's also now there is talk and development, mostly in Europe, but we're starting to see it in the US as well, is how to design cities that are heart healthy. And you can think of them as heart healthy, but they're really also healthy for, healthy aging in general. So these, and traditionally in the US, we've been kind of not densely packed cities. They're urban sprawling. The cities are people are moving to the suburbs and rural areas. So we have a lot of distances. We drive a lot. We rely a lot on transport and things like that, and cars, which can by themselves produce a lot of pollution, which is not heart healthy, and all of that stuff. So moving from this design of a city, which is a baseline situation, to this is one of the examples of a super block where you have a protected zone of no cars, and you have a lot of people are cycling, biking to work, going to working. There is a lot of fresh food, farmers market. There is green space, and so on and so forth. So you can actually start to design the cities to make the environment around you healthy, so that you have a reduction in your heart disease risk. So, we in medical school, through our residency, fellowship, training, and so on and so forth, we've been very cardiocentric, focused around the heart. And we started to think about what happens when we start to modify the risk factors. And then recently we started to think about what we call residual thrombotic risk. This is residual risk even after you control all these things from a clotting standpoint. So we started giving people or patients, we give them blood thinners and aspirin and other things, and to kind of modify this. And now more recently, there is an inflammatory risk, residual inflammatory risk, where we have trials and approved medications that can modify the inflammation even after you control your cholesterol levels and you eat healthy and so on and so forth. We need to control your inflammation to reduce your risk. But really, I think the paradigm is starting to shift into also understanding residual social risk and residual environmental risk. And you can think of these two, green and yellow, are your residual neighborhood risk, which is really poorly characterized in clinical practice these days, but it's something that carries a lot of information that we need to tackle and understand. So how can I always get asked about this as a clinician, what can I do? Or as a patient, what can I do? I'm not going to leave my house. I don't have the capacity to change how my neighborhood is designed in a lot of times. So what can I do? And it turns out that there are things that, this information can be helpful for us because we can actually treat what we know how to treat best. So for example, if you were to lower, we know that lowering blood pressure is good. The issue is, do I lower it to even lower levels? And it turns out that if you have a poor neighborhood environment, and when I say poor, doesn't mean necessarily financially, but poor from an environmental standpoint, then you could derive benefit by just controlling your blood pressure. So you can see in this exercise, we took a randomized trial called SPRINT, which randomized patients to either lowering blood pressure to the goals that we use these days, or a little bit more intensive lowering, kind of bringing down the blood pressure to even lower goals. And we basically looked at people who are exposed to high pollution versus low pollution in the United States. And we saw that the impact of treating blood pressure in people who are exposed to high pollution on the right side is dramatically higher compared with the impact that we get of this. So basically, this study suggests to us that your neighborhood also impacts the benefit that you get out of treatment. And I would suspect that we will see the exact same thing with cholesterol lowering. So there are things that just knowing that you are exposed to poor environment from air quality, from social, from this, allows us to treat you to lower targets because of what we know how to treat, which is by pills, by lifestyle interventions. We can design some interventions for you that are a little bit more intensive compared with people who live in a healthier environment, in case that the environment cannot be changed. What can clinicians do? There's a lot of things that we can do. Of course, just raising awareness, like I'm doing here in this forum, but also there's a lot of research opportunities. Of course, there's always opportunities for advocacy. So, how do you advocate with your policymakers, local, from the mayor all the way up to the government, and kind of how the federal government, and how can you kind of advance some of these agendas that really impact neighborhood health? There are other things that patients can do, for example, and this is just an example in terms of the air pollution impact. And you can say we have data to suggest that personal face masks and 95 specifically can lower your pollution level. Home air filtration, avoiding the areas, exercise, and other things are really impactful as well. Just a shout out to Achieve Greater, which is basically a big project that we're doing in the Cuyahoga Metropolitan Housing Authority. And the reason why I'm giving this shout out, because basically this is the epitome of how can we integrate the social environment with the natural environment to understand risk, and how can we modify that risk. So we're using cutting edge technology in the community, and people who are living in poor neighborhoods in terms of red line neighborhoods, high social vulnerability neighborhoods, people who are living in traditionally kind of underserved neighborhoods that have not had access to full care in terms of cardiometabolic care. And we're doing early intervention where we're studying the impact of early intervention that's intensive, that's modified, that's in addition to understanding the impact on social determinants of health. And this is where we use some technology like calcium scoring CTs and things like that, and in addition to wearables to understand risk, but also to modify risk. So in summary, I hope I convinced you that the neighborhood environment matters. And to a certain degree, it actually matters more than some of the things that we have been traditionally measuring and intervening on. Social determinants of health, which are interweaved with the neighborhood environment, these have significant impact on cardiometabolic health. And of course, we cannot forget about health disparities and inequities. And I showed you some evidence to suggest that the neighborhood can actually intersect with the health inequities and the disparities and the segregations that can really propel the pandemic of cardiometabolic disease. And without changing our policy, without understanding the neighborhood, without advancing this type of research, it's going to be very difficult to change cardiometabolic health the way that we. These are my funding. My team. This is Houston where I moved to, but this is what they show you on TV, right? This is the picture of Houston TV. They don't show you these parts, which are really, high social vulnerability of in every area that we live in the United States. And we see these micro segregation in neighborhoods and the poor investments in some of the neighborhoods that really propel cardiometabolic health outcomes. Thank you so much, and I'll turn it back to Dr. Sullivan.
Thank you, Sadir, and what a fantastic, amazing overview. I'm so impressed. Uh, Pretty much all of those studies have your name in some way, shape, or form correlative with them. So you've been a pioneer in this field and have so much to be proud of. There are a lot of great questions in the chat, and I have so many questions myself. One of the questions, Dr. Alkindi, is specifically about radon in the environment, your thoughts on if that is a concern as far as being the quality of life and cardiovascular health.
Yeah, no, this is a very good question, and I think there is definitely radon has been linked with variety of different health outcomes, poor health outcomes. I think it's a major issue, and I think it's still because it's a part of the code and part of the kind of a lot of the home inspections these days. It has come down in terms of the priorities in terms of cardiometabolic health, but there has been a lot of studies that looked into it. I don't have the most updated understanding of the numbers of how this impacts in the current kind of era of the United States. And this is an area that's transitioning very broad, quickly because there is a lot of measurements that are happening and the changing ways of how to measure radon and other things. But absolutely, I think all of the above. And reality is, it's very difficult to know. There's a lot of unknowns in this territory that we don't know, right? And we're always going to keep developing the field and kind of understand this one step at a time.
Definitely. And then certainly the focus of this kind of a forum is on cardiovascular health, but certainly, Dr. Alkindi, any thoughts on correlations on environmental factors and mental health? You touched on that on a couple slides, but thoughts on that topic?
Yeah, absolutely. And I think environmental health is a broad thing, right? And hopefully I convinced you that there is no one single domain, right? There has been a lot of different studies that looked into suicide, for example, depression, and air pollution has been linked directly with these things. There are other things like noise, like I showed you, has been linked with depression scores and other things in terms of even suicidal impact and so on and so forth. We know this both from an exposure from the outside environment, but from the internal environment. So there are some people who have tinnitus, which is that ringing in the ear, and they have significantly higher risk of depression and other mental health issues. So yes, there is a lot to be learned in the future. I think there's a lot more unknown than known. I think the mechanisms are still yet to be determined. How does that impact, and how can we intervene on it, and whether the interventions that we do have in terms of masks and kind of air filters and things like that, in terms of air quality, can impact mental health, but also whether simple things like noise canceling, earbuds, whether they can reduce noise that can be impacting health outcomes.
And then I know our audience is mixed of physicians, non-physicians, patients. From your presentation today, Dr. Alkindi, it seems like primary care is the forefront of this. They are the forefront of seeing these patients, identifying high-risk patients, trying to deal directly day to day with these social determinants of health. Any thoughts on how we as subspecialty physicians can help our primary care physicians, and or frameworks for how to have a multidisciplinary approach for this?
Yeah, and I think it all revolves around, quite honestly, revolves around a lot of the non-physician teams, right? I think social determinants of health will have to be incorporated into clinical care one way or another. There are mandates right now in terms of measuring, at least as a first step from Medicare, Medicaid, that we have to start to measure some of these, which is the first step, right? But I would say that it's not only around the physician. I think we have to think about the care team in general, whether it's physicians, it's non-physicians, nurses, community health workers, and of course, the earlier we can identify these populations, the better. There are solutions both at the local level, kind of the city level, and the federal level in terms of identifying, but also fixing. I think how do we, identifying is one thing, but also how can we intervene on social determinants? There's a lot of research about social determinants of health impacting health, sure. But the question is, how can we modify this? And whether modification of social determinants of health, albeit being helpful for quality of life, does it actually impact uh, our ability to reduce risk of cardiovascular disease? And I think this is part of why Achieve is happening, is really to develop care models that really become sustainable, but also pragmatic, that can be incorporated in parallel with medical care in the community to understand risk. And I think we as specialists, we always see the end spectrum, the end goal, not the goal, but the end of the spectrum of disease, where this severity. But in reality, a lot of the social determinants of health can be a risk factor for heart disease even before heart disease develops, right? So, identification of these patients by primary care using some of the centralized command centers, for example, population health approaches, I think might be the way to do it. But there's no easy answer here.
And just to play devil's advocate for a minute here, I think certainly medicine is an important way to intervene on social determinants of health. But how do we kind of balance that without medicalizing social determinants of health, for example? So where do we as physicians play a role? What's the role of the community? How do we limit healthcare costs and allocate resources appropriately? I think it's a fine balance.
Absolutely. I agree. I totally agree. And I think that's where knowing social determinants of health is the first step, right? I mean, at this stage, quite honestly, in the current status quo of clinical practice, you see patients in front of you in the electronic medical records. There is a zip code, there is a lot of information about the patient, but we don't know without asking the patient what is going on in your life. We don't know. We just simply haven't gotten to the point of measurement of social determinants of health or identification or screening. That has not happened yet, let alone intervening on it, right? So, but what I hopefully, I'm try to convince people here is that just knowing is important, right? And intervening is even more important. But without knowing, you cannot know which one to who to intervene on. And I think there are things that we can do as clinicians to actually intervene, both from medical standpoint, like I showed you with the blood pressure. So just knowing that a person has significant adverse social determinants of health can help you understand their future risk of bad outcomes that you want to prevent, and maybe can target lower blood pressure, lower cholesterol. But I think that this field is going to evolve into a little bit more pragmatic, but also personalized ways of intervening on social determinants of health. And there are reimbursable, everything has to be linked to reimbursement, unfortunately, but there are reimbursable models right now within Medicaid, for example, that reimburses you to identify, versus the hospital for identification of social determinants of health, but also intervening on social determinants of health by linking people to available resources such as food banks, such as transportation help, such as other things, housing vouchers and SNAP benefits and things like that.
Definitely. And one other question from the chat, maybe Sadir, Dr. Alkindi, your thoughts on the effect of the pandemic of COVID-19 on some of these different social determinants of health you mentioned. Certainly a role in mental health, isolation, availability of resources.
Yeah, no, absolutely. That's a fantastic question, and I think this is one of the things that I showed you this social vulnerability index, and social vulnerability index, although it's a social determinants of health index, for example, it has actually been shown that this is a metric that can identify neighborhood impact or a neighborhood suffering during natural disasters. So, in research which I haven't showed you here, we looked at what is the impact of COVID, for example, COVID-19 on both cardiovascular mortality, other type of all-cause mortality, other types of conditions by neighborhood. And we saw a significant increase in neighborhoods that are socially vulnerable compared with neighborhoods that are equipped with the resources to fight that, right? So if you think about, having a community center in your neighborhood or a golf course or whatever it is, or a shopping mart or whatever, then you can, your neighborhood is more equipped to deal with some of these pandemics, for example, because you can still, manage your life. But if you are in an area that does not have access to food and your transportation was cut down because of the pandemic, then, that can result in significant. So it's still an evolving area of research, but I would say that the literature suggests that COVID has worsened all of the above, with one exception, which is actually interesting. The air quality has improved transiently during COVID because of the reduction in emissions from cars and transportation.
Very interesting. Well, thank you for your wonderful presentation, your comments, Dr. Al-Kindi. I'll turn it over to Tiffany to wrap things up here.
Thank you.
Thank you. And thank you both for your time in sharing this information and answering the questions from our audience. If you could just go to the final slide, Dr. Al-Kindi, one note for the audience. If you are a provider attending today's live session, please note the CME code of 64404 on the screen to claim credit. Credit is only available to those who view the live webinar, not necessarily the recording. So thank you for attending. Please note that code if you need it, and have a great afternoon.